Hi, everyone. Good afternoon. My name is Grant Wells. I'm here today to present one of our MCHRI seminars featuring Dr. Katherine Bianco, who is a clinical professor within our OBGYN department within our MFM division, our maternal fetal medicine division. She will be speaking on placentation as it relates to bioage and how it connects to the genetics and the cardiovascular roots associated with long-term maternal outcomes. But before we go into that, uh, just wanted to do a few promo items and some upcoming events. We cannot do any of this work without our education committee. We are so thankful to those who dedicate their time to help us put on these seminars. If you are interested in joining this committee, we do have spots available, and we would be most welcome for you to join. Please let us know if you'd like to be a part of it. We have an upcoming seminar on Thursday, May 14th, featuring our institutional review board, as well as looking at and considering those considerations for community and in patient-engaged research. Really a wonderful seminar. Feel free to scan the QR code and come with questions and comments associated to all that work that you may be doing. Next, we have an upcoming seminar this coming Monday, May 18th at noon, featuring Dr. Sarah Bowling, who's looking at mapping the routes as it relates to the mammalian heart and how it potentially correlates to human health and disease. So really interesting seminar that will probably be one where many will come with questions and comments and potentially areas where it can relate to your line of research. And then another seminar shortly after that on June 16th featuring Dr. Kyle Lowe, who will be discussing something very similar and related, essentially creating human blood vessels, which also help us model vascular and developmental diseases. So that will be on June 16th at noon, and registration will be available on our website. We do want to make a quick announcement of the summer scamper that the Lucille Packard Foundation for Children's Health, as well as Stanford Medicine Children's Health, are sponsoring this summer. This will be on Stanford's campus. It's a really wonderful time for our community and your families just to show up and not only be together as a community, but also have some fun. There will be some tabling and some activities. MCHRI specifically has a team. We would love for you to consider donating, being a part of the team, joining, running, whatever in capacity you would like to do. We would love if you'd be willing to be a part of our team. So you can do so by scanning that QR code or using the URL at the bottom there. And then another really wonderful time for community that we are building in collaboration with Stanford Medicine Children's Health is this research community event, which will be Thursday, September 17th from 11:30 to 1:30, hosted at CAM in the Grand Rounds room, as well as just a really wonderful time to be together, learn about different areas within the hospital and what they're doing to support our research endeavors and how you can work more effectively with them or just learn about the different resources that they offer. Please consider scanning that QR code and attending. We think it's a really wonderful event just for people just to learn more about what everybody else is doing, which is such a valuable commodity given the busyness of this year, it seems. And then one new thing that we are hosting, if you have been supported by MCHRI in any way, please consider sharing a success story with us, whether those be awarded grants, publications, other major milestones. This tool will enable us a really great way to just share our successes on our social media platforms, in our newsletter, or just with our community in general. We're really passionate about the work that we support. And we're really excited by all the wonderful things that everybody is doing. So learning about all these different updates that are occurring are really helpful to us. So please do share that information with us and consider, just letting us know something major that just happened in your lab or in your research. And another announcement, we do have our annual MCHRI symposium coming up. It's on October 22nd, starts at 8 a.m., focuses on correlations to causation and eventually cures. And we have some really wonderful sessions as well as a keynote speaker featuring Dr. Alan Tita from UAB, and as well as some sessions not only on discovery, causation, and implementation, but also, as always, from our trainees. So registration is now open. It'll be at Li Ka-shing Center as it has in the past. Please consider registering now just to put it on your calendar. And eventually abstracts will be open, and we'll announce that so your lab or you can submit that information as well. But without further ado, really delighted to have Dr. Bianco here with us today, featuring this wonderful session. She really is a wonderful expert in caring for these patients, as well as her unique areas of research, and just very excited to hear not only her um, what she's here to tell us about this particular topic, but also how her background has contributed and her experience has contributed to this as well. So I will stop sharing and pass the mic over to Dr. Bianco.
Thank you so much, Grant, for this wonderful introduction. I'm going to be sharing my slides. Can you see them?
1 second, it's pulling up. I see them and now hit screen share.
I'm sharing the screen. Can I see
Yep,
them?
ready to go.
Okay, cool. Hi, everybody. I'm super grateful to be here and to be able to share this important topic with everybody in the community. MCHRI is such an important institution for the maternal and child health, and particularly for me, I've been very fortunate that I've been funded and supported all through. So a lot of this presentation has been supported and in great length for me to be here. So, quoting John Nash, the only thing greater than the power of the mind is the courage of the heart. It really speaks to what we're going to be chatting today in this presentation. As an outline, the presentation looks to highlight how placenta genetics and maternal cardiovascular health and biological aging can really shape the pregnancy outcome. So we're going to study we're going to look at very early studies of the trophoblast biology and metabolic profiling to advance the knowledge in congenital and acquired heart disease in pregnancy, and how these underscore how biological clocks might redefine maternal risk and resilience. And along the science, I will be sharing reflections through my career. So as the dendrograms shows here, placentation and genetics intertwine with maternal cardiovascular health with the ultimate goal to improve maternal lifelong wellness. So this very important intertwined network that is called the maternal fetal interface, it really needs to have a proper setting to have an optimal pregnancy outcome. If we have abnormalities in the maternal fetal interface due to hypoxemia or vasculopathies, or due to different aneuploidies, infections, we are going to see the result of increased risk for small babies, sort of preterm birth and fetal growth restriction, but also losses, stillbirth, miscarriage, and also incidents for increased risk for hypertension disorders. So this network is so rich to really guarantee a proper setting of the placenta and the pregnancy from the very beginning of the pregnancy, if you will. So it's the way that these units that called the cytotrophoblast invading the maternal circulation and then going into the uterus to really create the basis of the placenta. And what the placenta is to the mother, to the baby, to the pregnancy is really what is going to guarantee this very tight interchange network, and it becomes the lungs, the kidneys, the brain of the fetus. As you can see in this cartoon, it's just magnified where it comes. You have a fetus with a chorionic aspect where we can magnify it. You can see this intertwined network with this very unique cellularity called the cytotrophoblast, and then they get unifying. They are known as the in situ trophoblast. So early in my career, I worked in the laboratory looking at what we call the human trophoblast progenitor cells. And they come from the fetal aspect of the placenta. And I really wanted to learn the biology in situ in the laboratory and the molecular genetics to try to understand better a faulty placentation. In particular, as a geneticist, I was very interested in studying not just any pregnancy complicated, but pregnancy complicated with trisomy chromosomes, like meaning Down syndrome, Ehlers syndrome, Patau syndrome. So those are the most common aneuploidies during the prenatal period, if you will. And as you know, trisomy 21, also known as a Down syndrome, is the number one condition for live birth in kids with mental challenges. So this lead to many publications, and one that I want to highlight here is that when we look at the genetic difference of these different placentation affected by aneuploidy, we thought, well, if you have an extra copy of the chromosome, that would originate the phenotype expression in the infant, but really is not the case. And as you know, Down syndrome can have no implications of birth defect itself, but we have a cognitive deficiency. In the other hand, we have Down syndrome that they can go all the way to have severe cardiac defects requiring surgeries and severe leukemias, very particular type of leukemias, and all kind of abnormalities. So when we wanted to understand better what that means, utilizing the placenta and looking at whole genome expression, we saw this phenomenon that yes, you are going to see an increased dose of chromosome 21 represented in the genome, but it wasn't just that. It was also a whole dysregulation of the pathway within the genome. So it's a combined effect. We continue our quest to trying to understand better early presentations and way to really predict the outcome in the pregnancy. That this time I have transitioned to Stanford, where I have wonderful collaborations with MCHRI, with the PRC, and other institutes. So we decided to look at placentation early on and see if we could, and also maternal blood, to see if we could understand and identify early biomarkers in gestation that might perhaps would translate in hypertension disorders and actually help us to predict risk, as you can see here to the right of the slide. So with that foundation, I want to switch gears towards the maternal cardiac health aspect. And why? And here it is. It's a heat map of the world. So as you can see, maternal mortality ratios interpreted here would be increased as the color intensified. And there is definitely a need to continue understanding why is driven maternal mortality and what it can be done. So globally, we have a representation more towards a postpartum hemorrhage. So a lot of our moms die at birth still. But in industrial countries, sort of like the United States, we actually have an epidemic of maternal mortality more led by cardiovascular problems. So we have appreciated in the last 20 years that cardiovascular disease accounts for over a third of all the deaths in the United States. This encompass cardiomyopathies and other type of cardiovascular disorders. which is not the typical that we used to see as an infections, VTE, hypertension disorder. Some of this work have been highlighted in the media and in different places. So one large study out of Colombia, looking at birth certificates and deliveries, found a significant increase of maternal and acute myocardial infarct, which it really made us to raise our eyebrows and say, what is going on here? So what we learned is that women's delayed childbirth, we are going to see more comorbidities coming down the road. So there's an increased risk for gestational diabetes. There's an increased risk for hypertension disorders such as preeclampsia. The study show it, and that is an explanation as well of having an increased risk for cardiovascular affection and even maternal infarcts. Looking at data generated actually from the California effort of maternal quality care, we also see that there is a disparity in the presence of this maternal mortality in the United States, and they were established by different presentation of maternal mortality by state within the United States. And as you can see, there is a representation of 15 per 100,000 live birth in 2005, and we saw a sharp increase by 2014 to 21 to 22%. 100 live birth. However, we saw some states to have an increased pronounced representation in patients that are non-Hispanic Black women, ratios going up to 39 to 49 per 100,000 live births. So when the disparities were trying to be studied and understand what's going on, we looked at structural, institutional, and systematic barriers to health care. That's why it's so important to take into account social determinants of health. So demographic risk factors really impact the care of the patient. And we studied here by neighborhood, looking at the implications of increase of cardiovascular problems by neighborhood. So Black race, older race, tobacco use, alcohol use, drug use, also the type of insurance is all contributed to this disparity. So in this graphic here, I'd like it to refer like all the roads lead to Rome is this sort of similar when we look at etiologies that can lead to heart failure and pregnancy. So we have a big representation in cardiomyopathies. And I was telling you when we looked at these data from specifically the California audits from maternal mortality, we saw a big representation within the cardiomyopathies. And these could be either peripartum cardiomyopathies, could be inherent cardiomyopathies, could be hypertrophic cardiomyopathies. They were very well represented, but we also had ischemic heart disorders. We had a spontaneous coronary artery disorder, pulmonary hypertension, valvulopathies, and we have about 50% of representations between congenital heart disease and adulthood because those patients that were born in early 2000, early 1980s and 90s, now they're reaching reproductive age and they're having a very well health to be able to have families and continue building a normal life. But they represented one of the higher risk during pregnancy that we need to keep a very close eye. Arrhythmias itself is the most common complication that we will see in pregnancy, related or not to congenital heart disorders. So in general, when we look at risk factor for cardiac disease, race, ethnicity, social determinant health is something that we really need to keep in mind because health disparities are amplified. And I amplified by the time that we miss an opportunity when we have cardiovascular disorders and we don't miss the opportunity to address before pregnancy. So that's one of the things that big organizations like the American College of OB/GYN calls for, to really trying to do mitigation of the risk before pregnancy. Also addressing structural and systematic reasons impacting health disparity in this particular population. Seeing patients over 40 years old that now are denominated VAMA, very advanced maternal age. We know they are related 30 times over for risk for people younger than 20 years to have an adverse prenatal outcome. And the present hypertension disorder, which it rotates between 8 to 10% in all comers during pregnancy, it really escalates up to 13 times older in patients with cardiovascular disorders. This is just a workflow to think about it when we are facing perhaps a patient with cardiovascular disorders and that happen to be pregnant or postpartum, as we have learned that in period postpartum it's very important to continue screening these patients for any cardiac decompensation, heart failure. So pregnancy can mimic a lot of the symptoms that we can have with heart failure, sort of like shortness of breath, palpitation, even decrease of oxygen saturation, but these are the values that are no normal, okay? So you should not have shortness of breath at rest. Patients should not be needing to have more than 4 pills to sleep. Patients should not have resting heart rate over 120. That's not normal for a mother or postpartum. Same for hypertension disorders. The systolic pressure should not be over 160. And all these different red flags should prompt an evaluation by a cardiologist, primary care doctor, and a consultation for a maternal fetal medicine. Somebody like me, high risk obstetrics. So you'll be asking, well, so is any objective way that we can assess this patient's risk with pregnancy or as a preconception? And there is few standardized scores that we use in the daily practice. One of the biggest is CARPREG-2, that is the Canadian study that followed prospectively for many years, a pregnant woman. As you can see, 1,938 pregnancies. And here in the table, you can see the most common diagnoses that were representing this population and how was distributed between congenital versus acquired and others as such an arrhythmia representation. This is a validated tool. I would tell you, you can just Google it, CARPREG-2, and you'll be able to do the your own risk. You enter the quest characteristic that you're going to be asked, and it will come up with a score of what are the chances to have an event, an adverse cardiovascular event during pregnancy and postpartum. So things that, as you can see in this table here, that were validated and included in the system is up to 10 values. There are things like prior history, cardiac event, or arrhythmia, but also like prior cardiac intervention still count, even though have not been a cardiac intervention. The patient still have affection. And also like not enough prenatal care is a big contribution to this scale. The other one that is international use, very globally well known, is the modified WHO classification. And so you can see the risk classification here that goes from class 1 all the way to class 4. It will have no risk for the mother to all the way to class 4 to say pregnancy is absolutely contraindicated. And those are our patients that are pretty much having a less ventricular dysfunction to the point that the ejection fraction is less than 30%, your pulmonary hypertension, so you know they're going to be severely affected if they attempt a pregnancy, arthropathies with severe dilatation, so all postpartum, peripartum, postpartum cardiomyopathies with residual disorders. So in this graphic that I have here for you guys, I'm trying to put some numbers that you can have at the tip of your fingers when you think about it or talk to patients. So in general, if we think about it, women cardiovascular health, there is about 60 million women that are living with heart disorders or disease in the United States. And when you look at that, you have about 1.3 million of people living with congenital heart disease. It's a population that had grown and had reached, as I was telling you, reproductive age. So 58% of them are adult and only adult between 20 to 64 years old, but they also females. We have maternal mortality in the US, as I was telling you, due to cardiovascular disorders at number 1. So 1 in 3 maternal deaths are related to cardiovascular condition. I can't emphasize it enough. So it's the leading cause of maternal death. Heart disease in women is not just one disease or one stage of life. It's a lifelong journey, as you can see the representation here. Um, and it's important to trying to understand the biology, the hormones, the life experience, and how to care by different stages. And when we look at the world numbers, we see over 275 million of women worldwide and living with cardiovascular disease. And it's also when we see women who die of heart disease reported in 2023 in the US, we see over 300,000 of these patients. So one in every five females die of this cause. So it's not only important during and after pregnancy, but it's important as a general longevity in the women. So I could not emphasize enough that it's very important that we approach the cardiovascular care before and after pregnancy as a village, because it really takes a village to mitigate those risks and to try to decrease the chances to have an adverse prenatal outcome or a cardiac event during pregnancy and postpartum. So here's my village. I was telling you through these different opportunities of funding through the MCHRIs and support through Stanford. We have many learners in different levels, to be undergrad medical students, residents in OBGYN, anesthesia, fellows, and junior faculty that has embraced to continue researching in different ways. And I will share some of the data, how we can mitigate this risk for our maternal cardiac patients. The literature has come more and more asking for this and making calls to support improving the health care for cardiovascular disorders in pregnancy and postpartum. CMQCC has a wonderful toolkit that I encourage all of you guys to see it and download it and have it available, where they really go through a comprehensive, if you will, cheat sheet that you can use at the bedside with your patients. The American College of OBGYN partnered with the American Heart Association, come up with a wonderful practice bulletin by the ACOG that you can also really, it's lengthy, but it has a lot of data and it has a lot of clinical flow charts that are actually very didactic and helpful to understand how to work with this type of patient population. There's more prospective studies talking about the need for multicenter prospective multi-centered studies, but also to approach the patients as a multidisciplinary approach with many teams, creating what we call the pregnancy heart team. Here at Stanford, we actually have the opportunity to have the maternal heart team, where we have been taking care for these patients for well over 10 years, and I oversee with my counterparts in anesthesia and cardiology. And this, we have taken care of more than 500 pregnancy and counting from diverse cardiovascular affection. And we have the opportunity to offer all kind of support, not only during the pregnancy and postpartum, but as a preconception. And also if these patients end up required to have heart surgery or long-term follow-up with cardiology, have those follow-ups in place. Few of the research that we have done, I want to share with you. We look at the care of a multidisciplinary approach in this type of patients here at Stanford with anesthesia and cardiology. One of the things that we had interest was to look obstetrical outcomes and to look at the mode of delivery. A lot of these patients in early 2000 will be condemned to have an operative delivery with implied elective cesarean section. And we had seen and we have been publishing that how vaginal delivery is a reality, and we can having the opportunity to have a maternal heart program and have monthly disciplinary meetings help us to plan and to be able to really see what are the candidates for a vaginal delivery versus a cesarean section. We also look at other obstetric outcomes like at the preterm birth, hypertension disorder, and we are also studying most recently postpartum readmission. We're very interested to understand severe maternal morbidity and the implications in this particular vulnerable population. So SMM, as you can see, there are these type of characteristics. So looking at acute renal failure, eclampsia, need for blood transfusion or not, pulmonary edema, sepsis, and so. So in this small cohort of us, we saw a representation of postpartum cardiac event, such as pulmonary edema, arrhythmia, cardiomyopathy, failure, stroke, and we also saw SMM and at the time of delivery as well. So we took it to say, well, it's such a small cohort because it's just within the Stanford proper. Like we actually looked at bigger data sets. So we look at the live birth in California in the last 10 years. And here you can see we ask the question, do we see in severe maternal morbidity in this cardiovascular population? And we definitely saw an increase of cardiac SMM and pulmonary SMM. So we not only saw that this patient for sure have an increased risk of SMM, but they have particular increased risk for those. So having a multidisciplinary approach and a monthly basis, taking care of this patient as a team, it really mitigates the risk of cardiac event and adverse perinatal outcomes. Other thing that we are paying a lot of attention and integrating in our daily care is perinatal health, if addressing maternal illness due to mental illness. So we know that it goes hand to hand, and we're seeing how mental health is creating a toll in the perinatal outcomes and in the maternal outcomes. So we definitely look in some of the publications that we have been looking specifically at factors that can lead to mental illness during the perinatal time in this particular population. We looked at how two strikes, such as depressions, can be a risk factor for preterm birth in these maternal cardiac disorders. So at Stanford, we actually have the privilege to have a whole dedicated team for mental health due to philanthropic support. So our patients not only have support through social work, but they can have access to therapy and to prenatal psychiatric, which is a wonderful support. So what about the contrapart? What about the other side of the diagram? We also looked at the neonatal outcomes in maternal heart disease. And we know when we look at the maternal component with cardiac event, as I've been telling you, there's heart failure, stroke, arrhythmia, cardiac arrest, and even death. When we look at the neonatal adverse event, we can see prematurity, small for gestational age, respiratory distress, and death as well. So we really need to treat all these with a comprehensive approach that to look at a proper placenta setting, but also look at a maternal health, because that all will come down to the fetus health and the neonate, optimating the neonate health. So I like to highlight this also wonderful study from Canada that looked longitudinal cohort over 1 million women that had congenital heart disorders and how their offsprings had, as we know, an increased risk to develop that too. But those mothers that had offsprings with congenital heart disorder themselves had an intrinsic risk to have an increased risk for arteriosclerosis disorder, cardiac hospitalization, even cardiac transplantation. And at the same time, they were calling for patients that were having babies with congenital heart disease and they're being taken care of. They should reflect not only to a fetal echocardiogram, but also to themselves have a maternal echo, something that I call like mother, like fetus. We wanted it to address, as I was telling you, the mental health and the emotional status of these patients. So one of the medical students here at Stanford really did a beautiful study looking at adverse childhood event, ACE, and see if that was present and what was the significance in this cohort. So we saw that about 49% of our cardiac patients experienced at least one ACE. And not only that, they were related with fetal growth restriction. So this highlighted how really those mothers that had adverse childhood experience, as you can imagine, they were themselves patients once, down the road when they're mothers, they actually had implication in their pregnancy and in their offsprings. Another medical student at Stanford actually was very intrigued, like what happened to our patients in the fourth trimester. So in the part of the pregnancy when we already delivered, we're postpartum, and what was their an unmet need. And so she conducted qualitative and a quantitative study in these patients. And through these interviews and surveys, we learned that the patients really would like appreciated to have more frequent postpartum visits with their cardiologists, with the primary care doctors, and even with the obstetricians. They were okay to have telehealth visit because that would take a little bit of burden of bringing the baby with her to clinic, because they themselves are patients, so they themselves have their own appointments. So having the ability to telehealth was okay. And a lot of them were also asking for home visits if that wasn't a scenario that could be provided. We were also interested in, this is to other medical students and residents, to understand the uptake of contraception, but not only the uptake during with this multidisciplinary approach that we have at Stanford, but also where the unmet needs for disparity. So we particularly study Latin populations in Stanford since we have a large representation. And to our surprise, when our patients who were high risk obstetric were comparing with low risk obstetric, our patients actually had a higher uptake of contraceptions after delivery. And we think the reason that that happened is because we have such a dedicated and almost one-to-one care to these patients, that the contraception education and didactic and honoring the patient desire, it really was translated here where we did not see a health disparity in this vulnerable population. I want to emphasize the role of preconceptional care in a way that it is a time, a beautiful time where we can mitigate risk in cardiovascular patients with affection. Because we can look and see if there's any comorbidities that can be intervene, that it would decrease the chances of being translated in adverse perinatal outcomes. So if the patient have chronic hypertension, what type of medication is, or is she taking any medication? Obesity is any way that we can change the diet, work with a nutrition, perhaps lose some weight before we pursue the pregnancy. Diabetes itself that is becoming so prevalent. Can we have a better control if the patient is start pregnancy with high levels of hemoglobin A1C? We know we have 20 to 50% to have birth defect, miscarriage, and other infections. So can we intervene before that thyroid abnormalities? Past OB history is very important, because if we have recurrent miscarriage, if we have adverse perinatal outcomes, we actually can understand better what lead to those outcomes and how we can prevent it with different intervention, medications, and such. And one of the things that are very important is the mental health, as I was telling you. So making sure that before the patient embarks in reproduction is have a support system and mitigate smoke, drugs, alcohol. And for sure, with the cardiovascular population, this at time needs to be in very diverse medication lists, and some of them are teratogenic. So working with us, working with genetics, working with the cardiologist to change those medications before pregnancy, and making sure that the patient is doing well with the new regimen is essential to then embark in a pregnancy. Here should to share our cardiac sheet from the maternal heart program, when we meet once a month, and we meet with cardiologists, anesthesiologists, and maternal fetal medicine. And this cardiac sheet is entered into the Epic EMR, and it could be accessed in care everywhere in any place. So let's say the patient's hitting an emergency room with a distress, the team can read and educate it very quickly about the plan for this patient. If a plan for a C-section, a plan for a vaginal delivery, it's a plan to have it in a monitored bed, it's a plan to go for ICU after having the baby. What is the plan? So as you can see here, we're trying to also put risk category, include the New York Heart class, that is your functional class, but we also put the CARD-PREG and the WHO, so people can know if we have a high risk within the high risk population, or like cardiology like to call it a low risk within the high risk population. So now that I had tell you about placentation being key, the genetics of that, and the need to understand better maternal cardiac affection during pregnancy and delivery, but also as a window to the future, because pregnancy, it is itself is a cardiovascular stress test. I want to shift gears to talk about how we can improve maternal lifelong wellness and health. So with that in mind, I like to talk, I want to quote my friend John Lennon: count your age by friends, no years. Count your life by smiles, no tears. We know by the new CDC's numbers that maternal morbidity and mortality are rising, and there are particular raising in an age group that is over 40 years old. We've seen a 194% increase between 1989 to 2018, and that's going along with increase of pregnancy complication. And the major driver for this is aging. And here to the right in this table, you can see the maternal mortality, how it's been rising in that group. So we have a specific interest in how we can risk stratify these patients, and how, since it's going to become more and more prevalent in our daily life as a high risk obstetricians, and how we can have a parameter, a molecular biology parameter that can tell us that one thing is the chronological age, like when it's a sign because that's your birthday, versus what is your biological age. So there is many mechanisms trying to create this biological clock. We looked early a few years ago and supported actually by the MCHRI to the tip of the chromosomes and non-telomerine shortening, as a very well known that the shorter the tips of your chromosome get, the sooner that you're going to die. What is beautiful of that is totally modifiable. So there's extensive literature in psychology and psychiatric literature that with meditation and change in lifestyles, we can elongate our chromosomes and we can live longer. So with the same thought, we looked at in pregnancy and postpartum, and we also now recently are using DNA methylation to actually as another surrogate for biological age, looking at methylation clocks. There's many already existing, and I will take you through data, but we are trying to create our own methylation clock for pregnancy as it hasn't been validated. And so trying to put all into context, so trying to get a biomarker that can help us to determine better biological aging, not chronological age, not only because women are delaying pregnancy and childbirth, but also in high-risk populations such as cardiovascular patients. So we started with a preconception cohort, collaborated with the fertility folks like Dr. Latty, and here at Stanford. And we look at very advanced maternal age cohort, people that were going to fertility clinic trying to attempt pregnancy. And we not validated, but we run it all these already existing methylation clocks, and we looked at the rate of live births, and we compared chronological age versus biological age, and we could see those that had they looked younger by biological age had an increased risk of live birth. But we also asked the question, what about a composite pregnancy outcome? And those that looked like difference between the chronological age and the biological age, they had a better pregnancy outcome. So then with this, we took it to a prospective longitudinal epigenetic project cohort where we apply the same approach, looking at biological clocks, using methylation clocks, but these were a prospective study of low risk pregnancy. And what we see, some of these biological clock performing very well and show something that is interesting to us, and we continue to learn more about it, is perhaps pregnancy could accelerate within the person epigenetic aging up to 5.3 years. So it was also interesting to see that from all the different biological clocks, methylation clocks that we use, GRIM H2 was one of those that strongly correlate. So we have more interest in to understand the effect of pregnancy itself, but we also have interest in like how young you enter the pregnancy and how that can change after you has have a birthday, a child. So working in progress, we're looking at predictions of live birth with an in-house methylation clock that we have with collaborations with the Sabatino lab, looking at PRC2 age index. And we also have a prospective cohort study right now doing different time points, early in pregnancy, postpartum, and 1 or 2 years after, to not only see the relationship between chronological age and biological age before, during, and after pregnancy, but also after the years pass to see if it's a reversible effect. So wrap it up now. I want to take you for a different journey, thinking like into the future of these women that have satisfied reproduction and now they enter the fourth or fifth decade and they have the history, cardiac history. So how we can support into age with grace. Stanford had this beautiful journal from a few months ago where it say, if I only had a heart, and they would say ready in 1 hour through the 3D printing. So I think we're closer to that dream. Many data have come showing how women and cardiovascular health is intertwined to pregnancy and to reproductive risk, like losses, and how it's important to bring back hormone therapy to the table. I'm sure you keep up with the news that hormone replacement is something that is vital in the perimenopause period of the patients. I have it here as a traffic light where there are patients that are very low risk to embark into HRTs. There are those that perhaps might have a yellow line and you have to be an assessment, and that's where a lot of people land with the chronic hypertension and the diabetes. And those that perhaps that are in the stop sign that we initiating HRT might not be a good idea. So wrapping up all together in this closure slide, I want to take you through all the way to childhood to older adulthood. I want you to think about it, that these patients that we take care of them, we support them through the childhood, to support them through reproduction. They also need to be supported now through their midlife and older adulthood, and how we should integrate all the multidisciplinary care to guarantee different time of the journey in the women health, utilizing medicine, utilizing surgery, utilizing a multidisciplinary care of all the different realms in medicine. And because at the end it's a whole person care. And so with that, I want to say thank you for listening. Again, my name is Katherine Bianco, and I'm a maternal fetal medicine and geneticist, and you can always reach out and happy to talk or answer your questions.
Thank you so much, Dr. Bianco. We are so amazed by your presentation. We really appreciate all the time you put into it to present today. And again, thank you so much for being willing to follow up with questions with our audience. Please feel free to reach out to her, or if there's any follow-up questions as well, we're happy to facilitate them. Thank you very much for your time and attention to this wonderful presentation, and hope you all have a great rest of your day. Take care.
Thank you for having me. Bye-bye.